Hello, I'm Gregory Davis, gynecologist in Chico, California. Thank you for joining me. What we're going to talk about today is hysterectomy. If you've been told or you're at that point where you're thinking about having a hysterectomy or been told you need to have a hysterectomy, you've probably gotten on the internet, you've probably done some research, and you've probably gotten a lot of questions. And so what I'd like to do today is to kind of go through the different types of hysterectomy, talk to you about the different techniques and some of the things to look for, and hopefully this information will be kind of clarify in your mind and help you to make a better choice. Okay, let's take a look at the different types of hysterectomies. First of all, let's just kind of clarify something. When we're talking about a hysterectomy, hysterectomy means removal of the uterus. There's two parts to the uterus. There's the body of the uterus, and then there's the cervix. So from a physician point of view, a supracervical hysterectomy is where we leave the cervix and we take the uterus. But let's just, for practical terms, we're just going to talk about hysterectomy as removal of the uterus. Taking the tubes and ovaries is what we call a BSO, and that's bilateral salpingo-oophorectomy. So just the BSO means taking the tubes and ovaries. So there's three different approaches that your physician may take when they're choosing to do your hysterectomy. If you look today, what are the statistics in how hysterectomies are done? It's hard to believe this, but today the total abdominal hysterectomy, 68% of all hysterectomies done today are still done the abdominal way. That means you have to have an incision, usually a bikini incision. And that means that you're done in a hospital, means that you're going to be staying at least 1 or 2 nights, maybe even 3 nights, depending on how much or how big the fibroids were for whatever reason you had your surgery. But you can be prepared, you may be in the hospital for several nights. Laparoscopic hysterectomy, we call that laparoscopic assisted vaginal hysterectomy, laparoscopic supracervical hysterectomy, but it makes up about 14%. So there's not very many. The final type is a vaginal hysterectomy or total vaginal hysterectomy. It makes up about 18%. When I was in training, basically we just had abdominal and we had vaginal hysterectomy. Laparoscopic hysterectomy came along in about 1992. Now, let's just kind of talk about the nuts and bolts on the differences. An abdominal hysterectomy is done by a surgeon, may have an assistant, it's another surgeon, it may just be a scrub tech or somebody that's helping. The actual physical way it's done is the patient's laying on the exam table and the physician is really the only one that can see a whole lot of what's going on in the assistant. Anesthesia, circulating nurse, and even scrub tech, or if there's an assistant and then a scrub tech, they can't actually see everything that's going on. And you have to remember when I'm doing an abdominal hysterectomy, my eyes are up here, my hands are operating down here, so the distance in what I'm seeing, I mean, my vision is pretty good when I'm wearing my glasses, and it works okay. But the fact of the matter is that this comes into play when you compare that with what we do in a laparoscopic hysterectomy. But an abdominal hysterectomy, a little bit more bleeding, you're going to have a little bit more pain, you're going to have a little bit longer recovery. So if you have an abdominal hysterectomy, you're probably going to you need to tell your work, you're probably going to be out of work for 4 to probably, I would say, 6 weeks. I would tell your work 6 weeks. Now, when you have a vaginal hysterectomy, everything is done vaginally. So you're on the exam table, in the exam position, our surgeon's down, operating through the vagina, making an incision. So we're making incisions, we're clamping, we're cutting, and we're pulling the uterus, and we're pulling the tubes, and we're pulling the ovaries down towards us. So we're working up, and as we do that, this procedure, I mean, it's been around for decades, but I can tell you that you're not seeing, you're feeling. You're reaching up, you're feeling, you're putting clamps. And so most of the surgery is done where we really can't see too well. And so surgeons that are well trained in this, it works well and it's safe. The risk of infection still is kind of low. But if you've never done vaginal hysterectomies or you've done very few of them, it can be a little bit concerning because you really can't quite see things as well as you would like. Now, laparoscopic hysterectomy, as I mentioned, in 1992, Dr. Townsend was one in Sacramento that kind of pioneered this procedure. And I was in one of the first waves that did that surgery in 1992. And when I did those surgeries, and we were in training for a week, and I realized that we had these cameras attached to these scopes, instead of my looking through the scope with one eye closed and nobody else can see, now I've got a camera attached that's projected onto these huge screens. We got multiple screens, and the lights are off in the room. Everybody in the operating room is watching the surgery. Anesthesia, assistant, scrub, circulating nurse. So everybody is focused, because you can't do anything else, the lights are off. Everybody is focused on what we're doing at surgery. And now I've got this high intensity fiber optic light that's, now we got it in high definition. And I mean, I'm right up next to things, so the ovary can appear huge. Endometriosis can be seen. Adhesions can be seen. It's amazing what we can see inside. Now you can take pictures, and all of a sudden my patient can see these great photos. Now they understand why they're having to have their hysterectomy, because they got fibroids, they got endometriosis, they've got adhesions. It's hard for patients to it's hard for you to understand if you've never been in surgery what an adhesion actually is. But when you see it on a picture, all of a sudden you go, oh, that makes sense. Now I know why I'm having pain, because that was attached to my colon and pulling. So laparoscopic hysterectomy only makes up about 14%. And it's interesting because, you would think that there would be a higher percentage. But laparoscopic surgery is really, really a team sport. Vaginal hysterectomy, your assistants are really important because they're retracting so that I can see in this small workspace. But at laparoscopic surgery, everybody in the room is part of my team. And so it's interesting. Where I operate and where we do our hysterectomies, I have the same 3 anesthesiologists, I have the same scrub, same circulator, I have the same assistant on all my cases. So when we do the hysterectomy, we're using the same instruments and doing the exact same approach. And so that approach from laparoscopy is a little 5mm incision in your belly button, and then 2 little 5mm incisions by each hip. So when we do the laparoscopic technique, we just have 3 small incisions. We're doing about 90% of the work is done on these TV monitors. So I can see real clearly, it makes it so much easier when you can see what you're doing. So we do about 95% of the surgery, or 90% of it I should say, laparoscopically. We then go vaginally, and with the legs in the exam position, then we make an incision, get the supports to the uterus, and then we deliver everything out through the vagina. So the opening in the vagina is pretty small up at the top of the vagina. We close that, or I close that in 3 layers. And once we close that, we come back up inside, rinse everything out, make sure there's no bleeding, make sure there's no endometriosis that we need to take out at that time. And then we spray some numbing medicine on there, and then we let all that gas out of the tummy, and then we're done. Now, let's talk about some of the risk and the benefits of each one of these approaches. First of all, if we look at the risk of abdominal surgery, you're going to have a little greater chance of blood loss because you're making incisions in the abdomen. You're not tearing the muscles, not cutting them, but you're pulling those to the side. So you're going to have to put those back at the end of the surgery. So blood loss is a little greater at abdominal hysterectomy. Soreness is a little bit more. Recovery takes a little bit longer, and you're going to be hospitalized for 2 to 3 days. Vaginal hysterectomy, you're usually going to stay overnight. You're going to go home the next day. You're going to have some soreness. The soreness is going to be very similar to what you'd have when you delivered a baby if you delivered them vaginally. So you're going to have a little bit of soreness. The bleeding is not as much. Infection rates are pretty low, and recovery rates are actually pretty good. The laparoscopic hysterectomy is that, and those are now being done as an outpatient, and that's the way we do our hysterectomies as an outpatient, is that recovery is really quick. Because we're using very small incisions and we're doing very little surgery vaginally, we're not, like in vaginal hysterectomy, we're not pulling things down. We've already gotten everything freed up, so we're just removing the uterus vaginally. So laparoscopic hysterectomies can usually don't have much blood loss. Our average blood loss is probably 100 cc's or less. And recovery, we now do as an outpatient, so they're going home in an average of around 3 to 3.5 hours. And the recovery is, you're back to work, it's definitely in 2 weeks. And I've had some patients after our laparoscopic hysterectomy be back to work. If they don't have to lift, they can be back to work in 4 or 5 days. I have single moms need to be making money for their kids, and to survive, they're back to work sometimes in 4 or 5 days. So the restrictions with abdominal hysterectomy, you can't lift anything over 20 pounds for about 6 weeks. With the vaginal or laparoscopic hysterectomy, you can't lift anything over 20 pounds for about 4 weeks. As far as getting your incisions wet, well, now that's, in my practice for 26 years doing hysterectomies, what I've found is that when I do an abdominal hysterectomy, in 24 hours that incision is healed. That incision, or not healed, but it's closed and it's pretty much watertight. So I let my patients that have abdominal hysterectomies in the bathtub or soaking after 24 hours. Laparoscopic surgery, they're in the bathtub because we glue those incisions. Vaginally, we have sutures, and so we're having them get into the bathtub within about 6 to 7 hours after surgery. Now, one thing I want to point out, no matter which type of surgery you have, if soaking in the tub, I have found, is really helpful because it takes away soreness, it helps with the swelling, and it helps relieve the pain. Your vagina is a potential space. It's not open. So when you're soaking in the tub, there's not water washing up inside. So it's not really a problem for my patients after 24 hours. Obviously, you need to talk to your surgeon about that. But I find that it makes the recovery a lot faster. Now, let's talk about some things that really help with recovery after hysterectomy. The first thing is that anesthesia is really, really important. What we found, since we started doing laparoscopic hysterectomies in 1992, I had an anesthesiologist that wanted to put in spinals before my patients went to sleep. And he would put some long-acting pain medication in there, and so they had no pain for 24 hours. The only downside is that it blocked the nerves to the bladder, so for the first 24 hours they had to have a catheter. Well, that was okay. We took the catheter out the next day, and the patient went home after a day or two. But we've perfected it today, and what we do for all of our hysterectomies, which is revolutionized how our patients do, is no matter which type of hysterectomy they're having, and I really don't do vaginal hysterectomies anymore. To me, vaginal hysterectomy is like driving at night with your lights off. Once you've used to driving with your lights on, why would you ever want to drive with your lights off? So I really don't do vaginal hysterectomy. But when I'm doing abdominal or vaginal hysterectomy or laparoscopic hysterectomy, my anesthesiologist puts in a spinal before the patient goes to sleep. And they're kind of snookered, so they don't really remember that. We've talked about this. They've signed a consent. So we put that spinal medicine in, and they use a special needle. It's like a pencil tipped. It's not a sharp needle. It's a teeny tiny 25 gauge needle. They put the medicine in there. Patient lays down, goes to sleep. And now that spinal medicine is working throughout my surgery. And it's interesting. When you have surgery, maybe you don't realize this, but when you're having surgery, anesthesia keeps your brain asleep, but it does not take away pain unless they take you really deep. Well, then it takes a long time to wake up. They don't really do that for surgeries like this. So what happens is that if you're having traditional anesthesia and you don't have a spinal, your body's sensing pain throughout your hysterectomy. So what is your anesthesiologist doing? He or she is giving you narcotics every 15, 20 minutes throughout the surgery. So what happens when you get to the recovery room and you wake up? Well, you've got this accumulation of narcotics, and we all know what happens to that. Well, you get nauseated. So that's how people get sick and they get nauseated. So if we have a spinal working, then my anesthesiologist doesn't have to give my patient any narcotics at all. They've got the general anesthetic going, their spinal's working. So when my patients wake up in the recovery room, number one, they have no nausea. Number two, they have no pain. And studies show that if you're having surgery, especially this kind of surgery, and you wake up and you have no pain in the recovery room, your recovery's cut in half. How fast you go home, how much pain medicine you take, and how fast you get back to work. It's huge. And I would say that with orthopedic surgeries, rotator cuffs and knees, if you can have an anesthesiologist block that area in addition to a general anesthetic, your recovery, when you wake up with no pain, is going to be way faster. So with our hysterectomies and the patients wake up and they have no pain, our anesthesiologists are putting an antihypertensive in there. They put some clonidine. Don't ask me how somebody came up with that, but they did. And so my patients are able to urinate within an hour after surgery, but yet they have this spinal medicine that's working for 24 hours, sometimes 36 hours without pain. So my patients are able to go to the bathroom, they're able to walk around the surgery center, they're able to eat, they're taking their oral pain medications, and guess what? they're ready to go home in 3 hours. They go home, they can soak in their bathtub that evening, and that really seems to help. The other thing that when you're having your surgery is that you need to make sure that afterwards that you make sure your gynecologist talks to you about starting you on hormone therapy, because if you're taking your ovaries out, you're going to need to be on your estrogen, and we start it right in the recovery room, because your estrogen, when it goes out of your body after your ovaries are removed, takes about 8 to 9 hours as it goes down. If you put on a patch or you have pills or whatever you're using, it's going to start to work fairly quickly. That's why I like patches for that particular situation, because they work in about 4 hours. So now the estrogen is working, so you don't really have to suffer with any hot flashes or night sweats. So making sure that you have your hormone therapy to start on right after surgery is really important. The other thing I would encourage you to do is when you're talking to your gynecologist about a hysterectomy is that you really need to have a good discussion of what you're going to do if you're going to take the ovaries. If they are, you're going to be starting on your hormone therapy right afterwards. If you're choosing to leave your ovaries, that means just remove the uterus. Interesting thing is that 20 to 40% of your blood supply to your ovaries comes from the uterus. So when that uterus is removed and you still have your ovaries, they're having to get by on anywhere from 60 to 80% of their blood supply. Well, guess what happens? The ovaries may not survive and they may shut down. So even though you've had a hysterectomy and left your ovaries in place, they may shut down and not work. If that's the situation, you need to be prepared and let your doctor know, because you may need to go on some hormone therapy. So I explain to my patients, if we're leaving the ovaries, we're going to watch real closely to make sure that you don't need to go on some hormone therapy right afterwards. The final thing I wanted to go over is that when you sign a consent for a hysterectomy, it's really important that your surgeon talk to you about why you're having the surgery done. What's your diagnosis? Fibroids, bleeding, cancer, abnormal pap smears, whatever it is, you need to understand it. Then you need to understand that when you have a hysterectomy, you're not going to have bleeding, cramping, you're not going to have periods anymore, and certainly not going to have cancer of the uterus or the cervix if they're gone, or the ovaries if they're gone. The other thing they need to talk to you about is what is the risk of infection, the risk of bleeding, the risk of damage to bowel or bladder, the risk from anesthesia. Need to talk to you about alternatives. What are the other alternatives than having a hysterectomy? Are there different choices of ways to have a hysterectomy? They need to talk to you about what your recovery is going to be. And then the final thing is they need to give you the option to say, you know what, I don't want to do this surgery. And a second opinion is always a good idea. The thing I do on my consent form is I talk about the cost of the procedure. I think it's very important for you to understand that there's going to be a charge coming from me, a charge coming from anesthesia, a charge coming from the pathologist, a charge coming from an assistant that we have. So it's really important that when you go over a consent, all of that is discussed, preferably in the office before you get to the surgery center or to the hospital. I hope that this information is helpful for you and when you make your decisions on having a hysterectomy.